Well, thanks for your patience, everybody, and welcome. My name is Armando Contreras. I'm the president and CEO of United Cerebral Palsy. I'm just taking a minute to welcome you to the UCP Professional Learning Series co-hosted by UCP in collaboration with United Cerebral Palsy National Research Committee, Gillette Children's Specialty Healthcare, UCP of Minnesota, and UCP of Central Arizona. Today's presentation is by Dr. Angela Seiner, which is titled Cerebral Palsy, Early Evaluation and Intervention. In a moment, you'll get to watch an introduction and then Dr. Seiner's presentation, and after which there will be a question and answer session. I want to thank all of you for joining us. This is the third in our ongoing series. And I understand from the team that we've already identified our next 2 or 3 speakers. I'm also very pleased to say that our audience for this series is growing steadily, which is very gratifying. Our goal, of course, is to get the information out to as wide an audience as possible. At the end of this presentation, you'll be provided with information on our upcoming speaker and other related details, including how to get the recording of today's presentation. With that said, I thank all of you for joining us, and please enjoy today's presentation. Thank you.
Early in my training and education, I felt called to serve children with disabilities and special needs. I have a younger brother with cerebral palsy who, as the oldest sister, I certainly was one of his primary caregivers, being a second mother to him. So it felt very natural, and I understood that it was my calling to find a field in medicine where I could serve children with cerebral palsy. I came as a medical student on a pediatric rotation and stumbled into pediatric rehab clinic with Marshall Taniguchi and fell in love with the field. Then I was able to come back as a resident and spend more time with patients and physicians here. Then I spent 2 full years as a fellow finishing my training here at Gillette, and then had the fortune of staying as a physician for now 10 years. In rehab, we have the privilege of seeing children walking after rhizotomies, walking after orthopedic surgeries. We have the privilege of seeing children learn how to crawl, even though it's a little late, learning how to use communication devices finally, and interact with their peers at school. There's many joys and many wins and victories in rehab world. It's a privilege and an honor to work with a family on achieving goals as we step after step work towards the next goal, the next step, and to see a child and a family realize that and achieve that, it's a privilege and a blessing.
Angela Seiner, DO, specializes in pediatric rehabilitation medicine with a special interest in cerebral palsy, spina bifida, neurotrauma, and spasticity management. She received her Doctor of Osteopathic Medicine degree from Des Moines University's College of Osteopathic Medicine in Des Moines, Iowa. She completed a physical medicine and rehabilitation residency at the University of Minnesota Medical School in Minneapolis, and then completed specialty training at Gillette Children's Specialty Healthcare through a fellowship in pediatric rehabilitation medicine. She has made numerous professional presentations on topics including posterior fossa syndrome, autonomic dysfunction in severe traumatic brain injury, and spinal cord injury evaluation. Her most recent research has focused on the acute care of pediatric patients with traumatic brain injuries. Ladies and gentlemen, Dr. Angela Seiner.
Hello, thanks for joining today. I'm Dr. Angela Seiner. I'm a pediatric rehabilitation medicine specialist at Gillette Children's. Today we're going to talk about cerebral palsy, early diagnosis and interventions. We're going to review the literature and recent updates. Thank you. The talk today is going to start by discussing some presentations and definitions of cerebral palsy, so we're all on the same page and understanding. We're going to then talk about early manifestations of cerebral palsy, including screening tools and a timeline for diagnosis. Why early is better. We're also going to talk about evidence regarding early intervention programs in cerebral palsy and what we know. So defining cerebral palsy from the CDC is that it is a group of disorders that affects a person's ability to move and maintain balance and posture. Cerebral palsy is the most common motor disability in childhood. Those of you that work with individuals with cerebral palsy understand that it's heterogeneous. These kids don't all look the same, and they all have different histories from being born premature, term, or post-term. It is a group of permanent disorders that affects the development of movement and posture, causing activity limitation that's non-progressive. The developing brain was affected early, but the injury is non-progressive. And then as we talk more about cerebral palsy, we give it definitions such as motor impairment types and tone abnormalities such as spastic, dystonic, hypotonic, and then we talk about body distribution, quadriplegic, diplegic, hemiplegic. And then we know that there can be a vast array of comorbidities associated with cerebral palsy, from epilepsy, cognitive impairments, chronic pain, musculoskeletal complications, sleep disorders, and vision and hearing impairments. The incidence of cerebral palsy throughout the world is 0.1 to 2.2% of live births. Higher rates in developing countries with decreasing gestational age is occurring. These statistics are from a meta-analysis of 19 studies recently published. And we see that there's that increasing incidence with that younger gestational age, which is illustrated here by the numbers. We're seeing remarkable increased survival rates in the recent decades, and thus seeing more milder cerebral palsy, which can complicate and challenge us in our early diagnosis when presentations are subtle. So early diagnosis, we have 3 tools with the best predictive validity for detecting cerebral palsy at that early age, before 5 months of age even. The neonatal brain MRI is highly sensitive. And then we're also going to talk a bit today about prectal quality assessment of general movements with nice, highly 98% sensitivity. And then we're also going to talk a little bit about what the Hein and the Hammersmith infant neurologic exam is. But the combination of these assessments leads to a more reliable diagnosis along with that highly experienced clinical team. So early diagnosis of cerebral palsy requires motor dysfunction, that we're seeing the general movements are abnormal, or there's neurologic abnormalities from some of the testing. And we're also going to be looking for motor development at an atypical age, looking at some of those developmental milestones and when they're occurring. And then what also is required for this early diagnosis is that abnormal brain MRI, along with a clinical history with some of the risks. And this is summarized nicely and outlined. We're going to talk more about this fundamental, pivotal article by Dr. Novak that was published in JAMA Pediatrics in 2017. So high risk of cerebral palsy is also something that Dr. Novak in that article is teaching us that it can be useful when we're approaching a diagnosis of cerebral palsy early, but not quite sure we're landing on it perhaps, that it can be an interim clinical diagnosis. There's not an associated ICD-10 code, but it can help families understand and move along in the discussion of diagnosis perhaps. So if we spend a little more time talking about these general movements, Prechtel's general movement assessment, I want you to understand, if you're not familiar with this test, that spontaneous movement patterns are evident in newborns up to 20 weeks of age after birth, after their term age. The test is performed observing infants while they're awake and calm and not externally stimulated. And it involves watching and monitoring the whole body of the infant, watching for the variability of movements, complexity, fluence, elegance. And so the tester is watching for writhing movements up to 6 to 9 weeks of age. It can be less specific, and these can normalize, thus aren't our most reliable, but these fidgety movements can be present up to 20 weeks gestational age. So testers undergo extensive training, weekends long, days long in many instances. Prechtel's general movement assessment has shown to have better predictor reliability than some of the other general movement tests. So we talk more about Prechtel's specifically. This test is also evolving, where we're moving towards capturing infants even with phone apps so that we can do more remote testing, which will be really helpful. This test is really probably going to explode here in upcoming years as we understand other ways of using it and how to use it. So just a couple examples through pictures here to help illustrate that general movement assessment test. Because it is an effective and helpful test in our early diagnosis. Picture A here is video frames, so you read across like lines in a book. So baby A, these are two different babies. Baby A is a term baby with normal fidgety general movements. There's richer spatial and temporal variation with normal movements here. Baby B is a 28-week preterm baby with abnormal general movements. There's less variability, less variation. The baby looks to hardly move, essentially. This is another pictorial example, more recently published. Similarly, frames of a video are captured here to illustrate. And again, in this example, baby A has more typical general movements characterized by complexity and variation. You can see a lot of variability in this example. Baby B, you can see, has atypical general movements with marked reduction in movement complexity. You can see a lot of the frames are very similar and not variable. They are both 3-month-old infants in these pictures here, and baby B was later diagnosed with spastic diplegic cerebral palsy. Another test we were talking about utilizing for early diagnosis is the HINE, the Hammersmith Infant Neurologic Exam. There are 26 items that assess different aspects of neurologic function, reflecting that gross and fine motor function. It looks at cranial nerves, movements, reflexes, the protective reactions, behaviors, and there's age-dependent items also that reflect that gross and fine motor development. So this test is not paying attention to those spontaneous movements like we were just discussing in the general movement assessment. So the HINE is used most often in infants for 3 to 24 months of age. So the GMAs are for the newborns just past term, where we'll use the HINE more often in the just a little bit older babies. This is an example of part of the HINE assessment scoring sheets. So an examiner would pull this out potentially when they're examining the child and circle and find patterns in the abnormal ranges, and scoring with more abnormality, with more alarm, and more trending towards a diagnosis of abnormal tone, abnormal development, and concern for cerebral palsy. So this is a better look at the Novak article published in JAMA Pediatrics in 2017, looking at how early detection pathways are most reliable. So this is the foundational chart that explains how to early diagnose reliably, as best we can, infants. So the top of the chart, we start with detectable risks in our newborns and infants, and understanding some of the risks that might make us go looking at this chart. So preterm encephalopathies, neurologic risks, parent concerns even, and then some of the developmental delays here. And as we move down the chart, it breaks into the younger babies, less than 5 months corrected age, and over 5 months corrected age. The numbers in front of the tests lower on the chart here correlate with the article outlining some of the reliability and strengths of evidence of each of these. Some of these tests have more strength than other pieces, though they, kind of doing the best we can here. The oranger colors here are a bit less reliable, but again, even though part of the chart has a lot of orange, sort of the best we can right now for diagnosing, the best tools we have. So those younger babies, using HINE and MRI, GMAs more reliably. And then the older babies, again, HINE and MRI. The bottom part of this detection pathway moves on towards continuing to break down, understanding severity of CP, trying to predict severity of CP. So this is a very helpful, very useful tool as we move forward in understanding early diagnosis, and thus move towards talking about early intervention. And I wanted to make sure you're all aware that American Academy of Cerebral Palsy and Developmental Medicine also has adopted this in their care pathway sections, which is free and easily accessible to all. So this is essentially the same diagram to guide us, to guide those of us caring for these early infants at risk in our understanding for diagnosis and testing. So just so you're aware, that is easily accessible and free online if it's harder to get to the full article, though the full article is worth it too, certainly. So as we continue to look into the literature on how we understand early diagnosis, this article here, published in 2020, is a review of those infants that are without the perinatal risk factors, so better understanding how to catch those babies too, which is important, obviously, because it can be up to actually half of infants and children diagnosed with cerebral palsy do not have the risk factors. So some of these early cited features from histories, milestones, neuroexam that led to a diagnosis of cerebral palsy include that early handedness, less than a year of age, increased irritability, oral motor abnormalities with feeding problems, and then those abnormal milestones are broken down and explained here. Primitive reflexes could be persisting. There can be asymmetry in how hamstrings and legs are stretching, how hands are opening, or other signs that would indicate asymmetry in muscle tone and movement. Along with, again, they note fisting, scissoring, clonus, and toe walking. So this would be, somewhat more of a guide in maybe for primary care providers or providers that are not trained in general movement assessments and Hines, other ways to be watching for children that might be at risk of cerebral palsy. And just to better understand what is out in the literature and the movement happening, I'm not going to spend a lot of time here, but even better understanding how we can use updated imaging techniques. This is one study looking at diffusion MRI with term-corrected age to predict cerebral palsy. So just a few infants looked at, but better understanding how this imaging might help us. And these are just some beautiful pictures to kind of help illustrate that. Modern diagnosis of cerebral palsy has to include discussing genetic findings also. So genetic testing as a part of diagnosing cerebral palsy is also important to consider, certainly. Especially when the brain MRI is normal or non-specific. Just understanding that there's other steps to be taken. And then as we get into diagnosing cerebral palsy, we talk about better understanding functional levels. Gross motor function classification system is one widely accepted and understood and reliable tool. There are a few other functional classification systems also to help describe a breakdown in function among children diagnosed with cerebral palsy. For those not familiar, this tool also is broken down by age. So there's more challenges in the real young children under 2 years of age in using this tool or understanding future predictability, but it's very helpful. Lots of descriptions here if you go looking for this tool to help guide and understand future function due to the reliability of this tool. It can help with conversations with parents, families, and providers and caregivers around kind of what to expect, because of course that discussion comes next. So as we talk more about early diagnosis, we need to make sure we understand that we're understanding that brain development is occurring early on and evolving. So understanding early diagnosis and the importance of it is an important piece here. Early active movement and intervention are essential because infants who aren't actively using their bodies, using the motor cortex then, can have changes. So understanding the power of that neuroplasticity early on is why we talk about early diagnosis and early intervention. So understanding that the brain is changing in many ways for many months and years, really, but catching early on, we hope to have the greatest impact. Besides the impact that cerebral palsy can have to a child's body, so getting ahead of, as best we can, some of those impacts to muscle, bones, and development. So referral to cerebral palsy specific intervention is recommended with that clinical diagnosis of cerebral palsy or the suspicion, the diagnosis of high risk of cerebral palsy, as we were discussing. Or really it's recommended with family concern too. So this is a beautiful table illustrating that neuroplasticity and all the changes going on in the brain, the developing brain. This is published in 2021. So we talk a lot about the early brain myelinating and myelination and changes occurring in those early months and beyond. So to orient you to the table here, age in weeks and months and then years is across the bottom. These solid lines indicate active, very active processes. The dotted line are active, though less active processes occurring. So again, we talk a lot about myelination, but there's also apoptosis and pruning going on. Also, there's many processes going on in this developing brain. So this illustrates, the amazing things that those developing brains are doing and the importance of intervening early when it's needed. And again, supporting the strength of parents' perception. So a study recently published found that 86% of parents suspecting that cerebral palsy diagnosis before it's actually made. Delaying the diagnosis is harmful to the parent or caregiver well-being. It's understood. And early diagnosis can help foster acceptance and build confidence in the infant's medical team. So beyond directly the infant themselves, the patient, but the well-being of the family is important in this discussion also. So what is early intervention? Early intervention has been described as the term that describes the services and supports that are available to babies and young children that have developmental delays or disabilities, as well as the supports offered to their family. This can include a wide array of therapies or other services that help those needs of those infants and children. It can really have a significant impact on the child's ability to learn new skills, overcome challenges, and increase their success in school and life. So programs are available in every state and territory. Parents can refer, and services are free. Here in Minnesota, it's called the Help Me Grow program. It's based through school systems and in counties. Cerebral palsy specific early intervention maximizes that neuroplasticity again and minimizes deleterious changes to muscles and bone growth and development. So I want to take a look a bit at some of the early intervention literature. Unfortunately, it's not as strong as we'd hope, but best understanding what we have out there will be helpful. So looking at diagnosis of children with preterm births, these authors note that essential to treatment is the early detection of cerebral palsy to help ensure proper management, and essential to improving outcomes is harnessing that brain plasticity. So they're talking about it in the literature. Again, some of the literature here is disappointing. There's work to do. There's work being done. But these studies here I'm showing illustrate some of the weakness, heterogeneity in treatment interventions, smaller numbers of patients. These are from 2015 to 2017. Important work happening, but more to come, more needed. So this study here looked at some of the diagnosis and rehab services, a scoping review. They looked at many decades of articles, and their conclusion included evidence is sparse. So looking at NICU grads getting referred earlier, but children that aren't within that catchment having more challenges getting in for referrals. This article here nicely outlined implementation of guidelines in a multi-center system to help earlier diagnose and detect cerebral palsy, and they showed nicely that they were able to decrease the diagnosis age for cerebral palsy following implementation of these clinical improvements. So nice outlines for more to be joining in. So now I'm going to move into looking at some more studies that are published around early intervention programs, specific programs that were described. This first one here is about the game therapy, game style of intervention. It's a task-specific therapy approach based on active motor learning, family-centered care, parent coaching, and environmental enrichment. Unfortunately, the 30 infants enrolled, there was not a difference seen in Peabody developmental motor scores after enrollment. but perhaps it's a start, perhaps more is needed. It's something that's out there and described, so we're starting here in the literature. Some stronger evidence is coming out of the baby constraint-induced movement theory in infants, and this is one of the studies that is showing some promise as an intervention. This was published in 2018. There were 37 infants that had asymmetric hand use that were enrolled, ages ranging from 3 to 8 months, and they were assigned either baby constraint-induced movement therapy or massage. So they had hands-on, they had therapy, but the control group is the massage group. The constraint-induced movement therapy for these babies included donning a mitten on the stronger hand 30 minutes a day with OT visits weekly. So for this study, they had 6 weeks of therapy, 6 weeks off of therapy, and then 6 weeks back into therapy. At 1 year of age, there were 31 of these children with asymmetric hand use were diagnosed with hemiplegic cerebral palsy. 18 of the babies happened to be in the CIMT group, and 13 were in the baby massage group. So the measures used included the hand assessment for infants, administered at 18 weeks after enrollment. And then also the study found that there was significance between the groups. So the group that had the constraint-induced movement therapy had improvements significantly over the baby massage group. And then at 18-month follow-up, there were a few babies in the massage group excluded so that they could cross over into the constraint-induced group. And the AHA scores, the assisted hand use score, was followed for those babies. We did not have a p-value reported at that age, but there again was some sign of improvement in those infants that received the constraint-induced movement therapy. Another intervention program that's published and shared in 2019 was this EI SMART program for earlier intervention that focused on sensory motor development, attention and regulation, and relationships and therapy support. This is out of the UK. Some of the core components of this program, including actively involving, educating, and empowering parents, supporting that responsive parent-infant relationship, recognizing, supporting, and promoting the infant's self-regulatory behaviors, building infants' next developmental steps to stimulate and elicit active participation, and then modifying the infant's environment to ensure the infant remains challenged, able to participate in a variety of self-initiated, self-produced motor activities in a variety of conditions. So again, this common theme in early intervention programs of the parent support, parent coaching, some of the deficits they're noting in this article too, some of the challenges with responsive communication environment, early language programs often starting at 2 years of age, more work to come. This is another study looking at empowering caregivers to make their own decisions within their family situation, life situation, empowering caregivers to promote that sense of mastery over situations, positively relating to the psychological health of caregivers and may have long-term influences. This study enrolled 43 infants at high risk, unfortunately was underpowered, but again, some common themes in the studies and what's being published and some of the goals here. The COPCA program, Coping with Infants and Caring for Infants with Special Needs, was a family-centered program published started in 2011, this was published in 2020. Some goal-oriented coaching for caregivers and parents. In this study, pediatric physical therapists working with families. Themes in this study included supporting the infant in the home, supporting development, giving the infant more time for tasks and development, building caregiver confidence, really building that relationship with the infant. So next part of the talk, I want to come back to another beautiful article by Dr. Novak. So talking about the evidence in interventions for preventing and treating children with cerebral palsy. Dr. Novak was the author of our first big article talking about early diagnosis with the different measures in the graph. Dr. Novak, the lead author in this article too. This are stoplights, traffic lights, published in 2019. So this is a busy diagram, a busy slide, so I just want to orient you a bit. So the size of the circles indicates the strength of the randomized controlled trials, so the strength of the evidence of the measure being discussed. And then as we move up the graph, the strength of the evidence is better. So green, go stoplights, traffic lights, better evidence, whereas we come down to the line, the worth it line, and below red is, stop, don't do it because of the evidence. And again, smaller circles, less evidence, bigger circles, more randomized controlled trials, more evidence. So very helpful, very interesting, lots of information packed in here. If we focus in on the early intervention section, we see a lot of yellow, not a lot of green here. But reviewing some of the articles that we just reviewed, and we mentioned the COPCA, we talked about baby CIMT, constraint-induced movement therapy, which is up higher, almost getting into our green circle territory. And then game we talked about here too is in yellow. So, and smaller circles in this line. So more work to do, but getting started. And then as we continue to talk about early diagnosis and early referrals, looking at where there is strong evidence and where we can make an impact in these children that have some of these findings in parent outcomes and other areas to intervene and influence. And then understanding and illustrating the importance of this topic, if we take a quick look in clinicaltrials.gov, looking at cerebral palsy in infants, looking a year to 18 months ago, this search would have yielded just about 20 trials, and now repeating it this week yields about 50 trials or more. So more work being done, more work to come. These trials are in different phases of recruitment versus closure, but more to come, and it's important. And even at the federal government levels, this is being attended to and being mentioned in appropriation bills in recent years. So we're making progress, but more work to come. Thanks for joining today. I sure appreciate everybody's participation and ongoing work.
Thank you, Dr. Sinner, for your great presentation and being willing now to take questions from our audience. Just to our audience, I know it was said earlier, but just a reminder that you will get a follow-up email, and that will include the following: a short survey and about today's presentation, and then you'll also get the video. But let's first, before we do all that, let's go ahead and go to our questions. Looks like I actually have a question that I know gets asked to me a lot. And what if the diagnosis is wrong? Because it is such an early time in a child's life when we're looking at a diagnosis as early as I thought you said 3 months. What if that diagnosis is wrong? What's the downside?
Yeah, that's a good question. Thanks everyone for joining. My first time talking to you all tonight. I hope you didn't mind the recording. It's one way to do it. That's fair. It's, we want to be careful. There's different discussions happening around this early diagnosis. There's really been this shift to diagnosing earlier in recent decades. It used to be, don't you dare diagnose before age 2 or even beyond. So certainly meeting with experts and making the diagnosis carefully will be important. You see all the data from the first article with the graph that should go into making a diagnosis. So again, being very careful, gathering good information from physical exam, brain MRI, and meeting with specialists or even a team of specialists to carefully make that diagnosis will be important. And then I did make mention of, she makes suggestions utilizing the high risk of cerebral palsy. So not even the full diagnosis, but just if we're close to that diagnosis, being, as a way of almost putting that placeholder there to say probably, but we're still watching, still following and being careful. So good data, working with experts, and then sure, nobody's perfect. The world of medicine is not perfect. So what if we're wrong? I guess it's children with cerebral palsy should follow with their specialists. The field of medicine is evolving, genetics is evolving quickly. So I suppose that yes, it is going to happen from time to time where we don't get the perfect diagnosis, again, especially with medicine evolving. But sticking close to your specialist to reach the best diagnosis and continue to follow will be important. The benefits of early diagnosis would be that early intervention. So avoiding complications of cerebral palsy like contractures, supporting development with early therapy, supporting that infant's development. That's why we're wanting that early diagnosis. I see that question coming across in the chat.
Did you see that question come across in the chat? Because maybe I'm not viewing the full.
Yeah, I have the chat open. There's some other questions coming. I can keep addressing. I appreciate people sending questions here. So where should a parent go to get early intervention for cerebral palsy? It is going to be different in different communities. I made mention that there's early intervention services in every state, and they're listed through the CDC website. So I think in communities, family doctors and pediatricians know where to refer in each state and each community. For example, here in Minnesota, it's through the school districts and through the counties that's happening, where there's early intervention therapists available to children that are qualifying. And that early diagnosis or even early findings of delays certainly opens that door to more interventions and more support often.
So I may not be seeing all the questions because so if you're able to, you sound like you might be viewing some more.
Yeah, there's some good thoughts coming through here. So in my opinion, does early diagnosis really make a difference? That's a good question. It's a fair question because this early diagnosis, what we're probably doing is capturing more of the really mild children, falling in the lower numbers on those classification systems. So they're really mild cerebral palsy cases and patients. So they're the ones that often need less intervention or meeting their milestones more often. The kids that have more severe cerebral palsy, the higher classification levels, those are the kids that we, for decades, have probably been diagnosing earlier on. So that's where some of the gray area lies. What's the difference? So maybe, I think we're still proving to ourselves how much that early diagnosis is going to make a difference. I think it certainly does for some children. Does it for every child? I don't think I can hang my hat on that yet. But I think it's helping enough children that it's worth pursuing. You don't know that baby laying in front of you, which category they're going to fall into as far as will it help or won't it help. So whether it's the hemiplegia and treating that, we have good evidence for the constraint-induced movement therapy, that baby that might need that earlier on than we've been doing historically, or the child that's going to have an early gait abnormality or the early contracture development. As much as you can hold it off. I see another question. Even if you can't fully prevent every contracture, some of the kids with more mild findings that we're starting to catch earlier, we might be able to hold off or prevent some of those contractures, push them later in life, or open the door to more tools to prevent them.
So the questions just became viewable to me now. So there is a question here, which they want to know if they can get some of these. So it sounds like they're asking for written handouts, but maybe it's the journal articles that you were referencing. So I don't know if we maybe we can compile a list to be able to get, because they are great articles that you've referenced. There's some of my favorites in there.
Yeah.
So one of the questions I think as well too is that it talked about the role of parents. Where would a parent go to get early intervention just for cerebral palsy?
I talked about that a little bit, just referring to early intervention with primary care providers often, yeah. Mm-hmm.
Okay. All right. I probably was catching up with you trying to find the questions. I might have missed that one.
If people want more specifics around that question, just keep typing.
Okay. How does, okay, and I think this is also a great question too, but it also links to the parent piece is, you know, as a, and I think this is a catch-22. I see this as parents have concerns, right? But how are they able to know those early symptoms? And what is the trigger for them to go to that pediatrician?
Yeah, I mean, I think with questions, you should be going to your primary care provider. I think that's the great place to start. One of the early studies I showed through the talk was about those kids, those babies without risk factors. So the ones that were born on time and didn't seem to have any problems. Those are trickier babies to catch almost. And that's where, you know, I'd like to spend more time, where I think we need to spend more time too. So that article outlined what some of the risk factors might be in babies without the known risk factors around perinatal time, around the time they're born and things. So some of it's the developmental delays, crawling later, walking later. Some of it's challenges with feeding was a big one they noticed. And then abnormal tightness that most babies don't have, like more fisting than usual. And one of the older studies I shared was about parental concerns and just really validating that parents' gut feelings are often, you know, worth validating. It's worth talking to your primary care provider about those concerns. So we need to be doing our job as health professionals too, to support our primary care providers so they know how to reach out to the specialist, or how to sort out babies need more assessment and more workups also. So really, parents should trust their guts, talk to their primary care providers, and so that we can all decide, you know, how to keep an eye on these babies, whether it's early intervention or more testing or referrals to specialists.
So another question that has come in is, what is genetics' role in CP diagnosis?
Yeah, I only spent one slide there. I flashed through that really quick, which is does not do a justification, because that's really another booming, growing area of diagnostics right now, really. So that's sort of the second tier level. So once developmental delays or risk factors are identified, abnormal development, MRI isn't certainly giving us a diagnosis, then working with specialists, subspecialists on diving into that world of genetic diagnosis is really important, really an important avenue in fully diagnosing.
So this is from actually one of our affiliates. So thank you, Cheryl from Alabama. So she talks about what their affiliates are doing, but it's difficult. So I would agree, being here in Central Arizona, she's asking, how do you recommend reaching out and encouraging medical professionals? And really what she's talking about, I think, is, I'm assuming, is like that network to get these evaluations and get these referrals coming earlier related to these delays. So
I think we're maybe all working on this in our networks. I think what we're talking about at Gillette is continuing to partner with the primary care providers close to us and more further reaching, almost ones further out, you know, need us more. It really just continuing to partner specialists, primary care. This isn't going to be the most common thing they see, but, you know, it's certainly very important visits. So supporting that primary care team and reaching out to those early intervention therapists, they're catching the babies that have some risk, but helping, you know, really to partner so that we can work together as a team. I don't have a quick and easy answer, but again, I'd love to share ideas and hear where people around the country are finding success and how we can, do more. Is that what you meant, Valerie? Is that kind of where you're going?
Mm-hmm. Yeah, totally. So I think you might have kind of answered this, but Pat is asking us, is there a team approach to a diagnosis? Like, what is that team?
Yeah, certainly. The team might be different in different institutions, depending on how they build their team or who they have access to. A lot of time there's physicians, so it may be primary care referring, but in a specialty institution, it can be a physical medicine and rehab physician, can be neurology, can be genetics, there may be radiology involved, of course. And then a lot of times there's therapy specialists on the team, physical therapy, occupational therapy, even with the diagnosing. a lot of times it's physical therapists that are specialized in the general movement assessment testing. So they're a lot of times the ones working with those babies too. And then moving on to intervention, of course, there's a team approach and team work to supporting these children as they grow and develop.
So it's not in the questions, but it's a common question that we have seen. What if an MRI, sometimes parents don't want that. They don't want, to put their children under or to receive an MRI, or it's rural areas. So what happens when that's not possible?
Yep, I experienced that myself. Babies require some sedation for a good MRI. So if parents don't want to, pursue anesthesia, or there's complications or risks, then that is where we fall into more the category of discussing the high risk for cerebral palsy, or I support a child, we find interventions, we probably pursue early intervention and other therapies, orthotics, whatever might be needed, and using other diagnoses like that's less specific, spasticity, gait abnormality, and kind of continuing to discuss when the right time might be to pursue that MRI or other testing. So certainly we're following along, developing a relationship, and deciding together when the right time is for them, for their family, for their child to pursue testing.
Another question, lots of questions.
It's great.
Keep going. I can tell this is awesome.
I love it.
What factors help with long-term prognosis prediction? So, what factors help with long-term prognosis prediction?
So prognosis in cerebral palsy is it's tricky, maybe perhaps. So there's different spectrums of cerebral palsy. I was using the word mild to severe before. Prognosis, is really going to revolve around a family's goals, what their priorities might be. So some families want to work on walking or want to work on crawling. It's going to be those gross motor skills, versus different ages, different stages, different families. The goal becomes communication in any form, or eating in any form. So prognosis, I think the way I think of it becomes partnering with families and each individual child to work on those goals with the team surrounding them.
Great, still more questions. You're viewing them like I am, or did I miss? They're kind of coming in both directions, but you have touched on, I'm going to ask a question. Can I add to it?
Of course.
You have touched on the idea of the benefit of early diagnosis for intervention, and then you listed a lot of different interventions. So just your opinion, what have you seen to be what do you think might be most effective of all these different approaches? Because there are many. They're emerging, and there are many.
Yeah, the baby constraint induced movement therapy is really moving up the chart and gaining speed. I think that's certainly an area to watch, which makes sense when we talk about, the brain still developing. If a child doesn't use their hand at all for months or years, then we talk about the brain developing and growing, but also the brain, as it grows and develops, it prunes, it cuts cells, it severs connections. So early on, those early months stimulating. So that constraint induced movement therapy early on, I think, is one area to watch that's going to keep booming. As I said, it was almost up into those green bubbles and that complicated diagram at the end. And then the other ones, I'm not sure. I'd love to ask this group where they think, the future is too. I see common themes, certainly supporting families and empowering families to advocate for their children, to have hands-on, to be doing some of the, not therapy, but the support and the work for their children in some ways. We don't ask parents to be therapists, but certainly learning, stimulating play and learning, enriching environment and things, I think is really a focus of where some of the research is going and some of the common themes. Within that, I haven't seen a specific mode emerge, a specific therapy model emerge, but that's certainly a common theme. The trick is creating that therapy model, reproducing it, and then finding big enough numbers to have power. That's where some of the challenges in this research.
So you've talked about baby CIMT. Do you think that that's the most ideal or appropriate age for CIMT, or what is your thought process there? This is a question in the box. I just pressed it.
Sure, thanks. Historically, we've used constraint-induced movement therapy in older children, preschool, school-age children or beyond. So I think it continues to have its place there and have an effective place there. But the movement, this new movement, is to apply it now to babies, which is new and exciting. And so it may be that a child has constraint-induced movement therapy many times in their life, but starting with in the infancy may be another powerful tool. We may make more progress, is what we're seeing, what we're saying. So starting as babies and then maybe later in life too.
Also, there is one more question. Some cases may have it sounds like, okay, the question is some cases might have delayed response to the diagnosis. So maybe I'm thinking that means is that sometimes it's not obvious that there is a problem for the child. And so we know that's why sometimes we see a wait and see. So so the question is what is the response to, if there's a delayed response to the diagnosis? Some cases might have a delayed response to the diagnosis. So try to answer that. I'm trying to interpret, and I don't think I'm doing a good job.
So, I think in healthcare, we're doing the best we can. So catching these children that need intervention as early as we can is the goal right now. So for catching them a little later, catching when we can. So expanding the net to catch them, educating early intervention, educating primary care providers is going to be key. There was some comments around responsiveness to the diagnosis. Parents struggle, or you worry that parents will struggle with the diagnosis. But again, some of the literature has shown that it's reassuring that a lot of times parents are suspecting something's going on, what's going on. So parents often, find support and reassurance by having a diagnosis, by being heard, by being understood. And certainly the right professionals are going to meet parents where they're at. We don't dive in. Some parents aren't ready to dive into the 18-year future of cerebral palsy in our first clinic visit. So, we meet parents where they're at and evolve in the discussion and the diagnosis, certainly.
There are some recurring questions about CIMT with adults. Do you want to touch on that?
Adults, CIMT. Yeah, I don't take care of adults most often. I most often take care of children. But anytime you have a tool that works to strengthen, stretch your weaker hand or side, it can be useful. So again, at older ages, other ages, it can be used as an intervention.
I do know we actually have a clinician, one of our occupational therapists did adults CIMT back in the 80s and 90s. So I think it's actually where it originated, is if I understand correctly, some of the things that I've read. So
probably the stroke literature too, after strokes in adults. Yeah,
right. So anyhow, am I getting all the questions? Because we are coming up on the hour.
Oh, here's a question that came through. Patricia, thanks. You're active. I love it. Hippotherapy. Hippotherapy is, if we spent more time on that red, yellow, green bubble sheet, hippotherapy is nicely up towards the top in green. So yes, I have lots of patients that use hippotherapy. And there's some nice evidence for it. It's a great tool. So horse therapy, but more hippotherapy.
So, okay, as soon as I said that we're up on the hour, people are like, no, wait, we have more questions. So this is awesome.
Good enthusiasm.
So I'm going to take this one. What is the role? I think this is a great question. What do you think about the role of a generalist in early intervention as opposed to employing therapists in these roles?
Yes, a general physician, provider, you mean, you think?
I think she's talking about physical therapist, occupational therapist. And I'm going to assume that it's related to just, treating children with cerebral palsy. Oh, here she goes, developmental specialist teacher. Okay, so in early intervention, we have developmental specialists, which are more generalists. And so she's saying to employ those to treat these children with cerebral palsy. Keep sending in, Cheryl, unless I'm interpreting you wrongly, wrong, as opposed to bringing a therapist on to serve that child. What is your thought process?
So if see if I'm on track or not, send more comments. So if a primary care provider is meeting a family and there's concerns about the child's development or if they're at risk for cerebral palsy, referral to earlier intervention brings in more regular services. So oftentimes a primary care provider will only see a baby every month or two, and then as they get older, every 3, 4, 5 months. So an early intervention specialist is often seeing that baby every week or every other week in the home, often COVID anyway, but in the home, more frequent. So seeing that baby grow, develop hands-on with the family, with the parents, teaching them how to, again, stimulating environment, stretch, and find other equipment or interventions that might be needed. So the therapy support is more frequent intervention and a different level, different training than what a primary care provider might focus on. And then certainly we all couple with our primary care providers because the specialists, pediatric genetics, pediatric rehab, pediatric neurology is harder to come by than from the other areas. Do you think I'm close, Valerie? Any more comments?
I think that is, well, and okay, so being the therapy director that I am, I would also, I feel like what we're seeing in the literature that the intensives are really important for these kids with CP early on, and that those bursts of intensives, and I so I can only speak to my own state, but typically that is not typically something that's available through early intervention in Arizona, and it's and it is early intervention just nationally is designed to be a coaching model, and so while I think it has its place, I think that absolutely, I think having a therapist involved who has that knowledge, and then also possibly even, having just, I guess I question as a clinician that the coaching model is the appropriate answer for children when so much could happen at this time. You know what I mean? So much work is needed to be done. So.
Yeah, again, this is another area where I meet families where they're at. If they have time, energy, resources to do more outpatient therapy, or gosh, even some families travel to those intensive spots, supporting them. But if it's straining the family, straining the budget, I support them in being mindful of that too, as much as possible.
Right.
Yeah,
right.
but right. I don't know if we have enough evidence to say every baby must go to Michigan for the intensive court, things like that. So I think using local resources as best we can right now seems to be enough.
The ideal is to have both.
Yeah, right. For sure. So we probably need the literature to prove it, to tell insurance to pay for it, right? We got to keep doing our work as specialists.
So there is a question. You're getting a lot of, so you did open a can of worms here. So what is the frequency you would recommend for CIMT daily? 1 time a day for 30 minutes, I think is what she's asking. Research quoted suggested 1 time a day for 30 minutes. So they're already looking up your work.
Yeah, that was the article that I had up. It was that much. That's pretty mild in the world. That's pretty low level of intervention in the world of constraint-induced movement therapy. Typically that splint goes on for a month, or more, people that understand this therapy. So there's a spectrum of intervention, whether it's half hour a day, 4 hours a day, 8 hours a day, or 24/7 for a number of weeks. I think the work needs to be done again to show where it makes a difference and where the greatest difference is found. So there's that dosing factor that we don't know. We'll see.
Sorry. So here's another question that we have. First of all, she loves all this conversation focusing on empowering the families, and I would agree with that. She wants to know what are some of the tips you have for opening up the conversations with families. So a general response she gets from families when asking about specific child family-centered goals for these children is, "You're the expert, you tell me." So how do you get away from that?
Yeah, sometimes it can be overwhelming when you're starting with a family or they don't know where to start. I I think I just keep talking different areas and see where their faces light up or where it might stimulate them more, or give them another session or another visit to kind of ponder and focus. I think they evolve. But, as the expert, maybe giving them I think I give ideas and kind of keep talking and see where we meet.
So we do have, so there's a question here, which I think is great. Is CIMT effective for spastic diplegia?
So constraint-induced movement therapy involves a hand. So and spastic diplegia is usually a diagnosis of just the legs being affected. So constraint-induced movement therapy often involves a hand. So triplegia or hemiplegia. So whenever, or even quadriplegia, but so more an arm involvement.
So we're getting a lot of comments. I'm trying to. People are excited about this. It's awesome. There is a question from Diane about seizures. How does that affect your care for a child when a child has seizures on a routine basis? So she said coping with seizures on a routine basis.
Yeah, certainly epilepsy is not uncommon in cerebral palsy. It's one of the associated findings. So certainly it's different for every child, but working with your neurologist to control them as best as possible. Certainly that's a balancing act between medications and side effects versus the effects of seizures. Excuse me. So, kind of doing the best you can, certainly. I'm not sure if there's other specifics around that, Diane, that you were hoping for.
There's a lot of, we sparked something with the developmental specialist. So it's basically, I think a lot of people I think that we've sparked a couple different, really people feel very strongly about the CMT, the family involvement, and then the developmental specialist, but I don't see any more questions. So if you all have any more, it's that one from you, Connie. Okay, so she's been a pediatric PT for over 30 years, and it seems like in her earlier career, she heard that cerebral palsy diagnosis often, and for many years, she rarely saw that diagnosis, and now it seems to be so much more of an emphasis on the diagnosis of CP. Oh, I think that's a great question. I can relate to that. Can you comment on that?
Yes, so certainly we acknowledge that we are evolving to be diagnosing earlier. So I don't know if if you're taking care of more infants and toddlers that you're seeing more of it. We're pulling more of the diagnosis earlier. There isn't necessarily in the last couple of decades a huge increase, like in percentages. There's probably more mild babies being diagnosed as we're doing better in NICU treatment and NICU survival. But as a whole, there's not necessarily a huge increase in the incidence of cerebral palsy. So it may be that we're shifting into your populations more, where we're catching, so catching them earlier, or catching them in your area. Connie, I appreciate your experience and work.
I think we definitely have seen in the States the decrease in severity, but we need to catch up with Australia, who's actually decreased their numbers. So that's what,
right.
All right, just making sure that we have it all. So we were actually so the presentation was given 90 minutes. So we certainly can keep going if we want to continue to ask questions. But it looks like we have answered all our questions. So thank you again, Dr. Sinner. I think, do you see any questions that I missed?
Valerie, I think there's one more in there on the Q&A.
Well, Valerie's reading. I'll just thank everyone for participating too. I sure appreciate everyone being here. It's a varied audience, I think, but coming together is sure important that we continue to collaborate and work together.
Okay. I think our question that I missed is, when should we be encouraging PCPs to pursue a diagnosis? We have kids who don't get a diagnosis for several months, and it undermines parents' confidence in us as clinicians because we held back, possibly. So held back on those discussions.
I wonder if that's coming from an early intervention therapist or something. Again, I think it's the collaborating specialist to primary care, that early article I shared about the kids without risk factors. So identifying that those findings, the developmental delays, the feeding difficulties, the tone and fisting, that those are real and real enough. Maybe sending them that article even. Let me know if you need it. So some assistance and education and collaboration. I sure appreciate you and the good fight from the front lines there. I think I hear that who asked the question is acknowledging that earlier diagnosis is important, and certainly we need to work together. It's tricky too, you all therapists on the front lines, not over alarming and stressing out your families, but needing the primary care provider to push along and place orders. It's a tricky spot to be, but the relationship you have with those families is so powerful, working with them week after week or month after month, more than we as physicians get to. You see so much, and it's so important. So, calling the primary care provider's office, sending a note, I think is important. Or knowing who your primary care providers in the community are that you can trust too.
Okay, it sounds like it does sound like we're getting some feedback that people would be interested in some of those articles. So we can certainly help you with that. So you don't have to, we can go through and grab a few of those. That would actually be a fun follow-up to this discussion. There is a few questions like where specialists in different locations. I don't know if that we could answer that unless you can, is like a specialist in New York for CP. But otherwise, I feel like we've probably answered them all.
Like early intervention can be found through the CDC website. Again, I think primary care is a really nice place to start. They know your community in each state, including in New York, and know where the specialists are at. Does the community have access? And our American Academy of Cerebral Palsy does have a database. The community must have access there. So that would be another resource to find cerebral palsy specialists. You can search in there. So it's like American Academy of Cerebral Palsy would have lists there state by state to search.
Yeah, okay, yes, you're right. That's actually, I've forgotten about that. That's actually great.
That's how we find people when patients are moving out of state, I think sometimes.
Yeah. Okay, so we have this. We'll make this our last question and then we'll wrap it up. What do you suggest in addition to empowering parents, what strategies can be used to get a child with CP to be more willing to be involved in therapy as they grow older?
Oh goodness, I wonder if you're referring to some of those preteen years. They are challenging. So using that as an example, I guess it's, trying to find what's motivating. Again, the therapists have the advantage of knowing the patient, the kid so well. I try to, but in my viewpoint from a clinic visit less frequently, I ask what motivates a child, whether it's, a lot of times in this population, we talk about regular exercise, trying to keep them active to treat tone and contractures and keep weight at a good level, et cetera. So a lot of times I'm counseling teens on staying active and finding exercise modalities. So finding out what they like, whether again, it's hippotherapy or video games, but the big active like dancing video games or getting them on YouTube and finding fun exercise videos. So in that area, looking for what's motivating. And then I call out the parents to make it a family activity too, a lot of times, get the family involved. But parents can't do it for kids at that age, especially. So the kids have to be motivated. The patients have to be motivated. I welcome comments or ideas too there.
All right, well, thank you again. Just so that the audience does know that, first of all, the slides, there will be slides that will be available that have been requested by some of you. Also just know, again, I already talked about the survey. Also a link to the recording of today's presentation will be available to you all. Do us a favor, if you will share this with your friends and colleagues. While you get the CEUs or the CMEs, really our goal at UCP is to get information about best practices for children with cerebral palsy out there in the community, because as we've all discussed, there are a lot of people who are not, this is a new paradigm shift. And so we want to get the word out, particularly regarding the early identification and the early intervention for kids with cerebral palsy. The other thing that will be in this email, so a survey, your recording, and then information about the upcoming presentation. And based on your questions, you guys will all like this, because the next presentation, as you can see on your screen, is on February 24th, and it's with Darcy Fellings, and her presentation is titled Constraint Therapy for Children with Hemiplegic CP, What You Need to Know from Brain to the Clinic. So, and also, if you are eligible for CME or CEU credits, you will receive a separate email with your certificate. This does take a few days, so do be patient with us. We're all volunteers, but we will promise to get that to you. Also, we appreciate and look forward to any additional comments or feedback that you'd like to offer. You can absolutely email me, Valerie Pieraccini, here at UCP of Central Arizona, or you can email Tara over at Gillette Children. So you can see that on this slide as well. Another option for that is that you can just reply to your Eventbrite notice that you will receive, and the email will be forwarded to us. So thank you, Dr. Sinner. Thank you all again for joining us, and have a joyful holiday. It's coming up so soon. And we'll see you all next time on February 24th. Bye now.